Thank you, and thank you for being a part of CVI 2020. So in the next several minutes, we're going to be talking about tissue bridge removal and mitral valve replacement. These are my disclosures. So let's start by looking at a case. This is a 77-year-old man who presented with severe symptoms of dyspnea. He was essentially class 3 with chronic renal failure and prior coronary bypass surgery. He had an ejection fraction of 35% and severe symptomatic secondary mitral valve regurgitation. So when we think about these patients can actually present quite a complex management dilemma. When thinking about the options in this patient in terms of transcatheter therapy, there is repair and there is replacement. Now certainly repair is associated with a shorter length of stay. It does not involve a prosthesis. There's no transapial access required, and it is widely available. In addition, we know that from the recent COAP studies that it can be life-saving in appropriately selected patients. On the other hand, with transcatheter replacement, there is no residual MR, which may be a significant and important goal for a number of patients who have severe MR on their presentation. Now the challenge here is which therapy to offer, and certainly there are randomized trials that are addressing repair versus placement in the pivotal clinical studies ongoing right now. But in discussing these options with this patient, it can be actually a very difficult choice, especially when you're thinking about enrolling patients in those studies versus offering a transcatheter repair solution that is currently available. As a glimpse into the future, I'd like to share with you some experiences that we have had in terms of tissue bridge removal and transcatheter mitral valve replacement. In other words, the ability to do both transcatheter repair and also replace the mitral valve. This is an 80-year-old man who presented with previous transcatheter repair performed elsewhere, and he had been treated with MitraClip. And you can see here in the top left-hand corner that there is one clip that's an SLDA. There is also another clip that is intact with the tissue bridge that is remaining, but the patient has severe residual MR and also a mitral gradient that would not allow us to do additional clipping because of the risk of mitral stenosis. He was 80 years old and he had multiple prior stenotomies and was not felt to be a surgical candidate. So he was first evaluated for the possibility of TMVR with use of the tendine prosthesis. And this is an overlay with cardiac CT for planning the procedure, and you can see here that the neo LVOT is 478 square millimeters, showing that with overlay of the prosthesis that there would be expected excellent result in terms of using this device for replacing the mitral valve. And this modeling was done with the clips in place, as you can see there on gray on the left-hand side. So in this first human experience, this is how it is done. We do 2 transeptal punctures. There are 2 steerable guide catheters that are placed into the left atrium. We then use a snare to pass a wire around and grab the wire for externalization, followed by exchange for a coronary wire that has been denuded on its inside at a V that is placed at the side of the tissue bridge. With application of energy and with some manual retraction, you can see on the right hand side that the tissue bridge is then cut, and we then do this with the TMVR device in place ready to go because we are not certain that the patient will be able to tolerate the MR acutely. So this is what it looks like. On the top left hand side, you can see this is after the tissue bridge has been cut. The TMVR device has been placed in the center of the mitral valve. It is then extruded in its typical fashion, and there's complete relief of the MR, as you can see here in the bottom middle panel. On the right hand side is a fluoroscopic view showing the tendine prosthesis with the clips, which have been passed onto the posterior side and essentially are pinned in their position as a permanent SLDAs in the mitral valve. We can also do this technique in patients with multiple bridges. This is another example of a patient that we've treated, and this is done with, again, 2 transeptal punctures, snaring the wire in the left ventricle, as you can see on the left hand side. We first decide to go after the medial bridge. There is then a medial cut, and the second from the left, you can see there. We then use the same 2 transeptal steerable catheters to then snare the lateral bridge in the middle. We then perform the lateral cut, and because this is the final cut, we have the Tendyne TMVR device in place. And then we do the final deployment of the TMVR on the far right hand side. So in summary, I've shared these cases with you to illustrate how tissue bridge cutting in patients with prior MitraClip to facilitate TMVR is now feasible. And I do believe that this possibility will enable both complementary transcatheter repair and replacement in the future. Thank you very much, and I would be happy to take any questions from you all.